afternoon, everyone. We're just admitting people to the room. I hope you can see the screen, which will be the lineup of our speakers today.
It seems we're at capacity. A couple of people are saying, Kate is saying she can't get in because it says at capacity.
Oops. Okay, we did not think we would have so much interest. Could we ask comrades from the NGOs, if your group is already represented here, to, if you wouldn't mind leaving so that we can allow in the speakers and media, if you don't mind. The entire press conference will be recorded and we will share it with everyone after. So we do apologize. We really didn't think that more than 100 people that would be interested. So I'm gonna, Joan, apologies everyone, Joan, are you making progress on the waiting room, or do we have 2 minutes to resolve that?
Sorry, I'm working on it.
So I think if we, apologies to everyone and just for your cooperation, if we can prioritize journalists in the room, please, because it is a press conference, and to ask NGOs or comrades whose organizations are already represented to make way for the journalists. We'd really appreciate it. Thank you. Okay. Thank you everyone for your patience. So just a reminder that we're prioritizing journalists for now. And that in the next minute, we're going to have to start the press conference, please. So again, we're just urging NGOs and our comrades to, if you don't mind, and we apologize for this, to make way for the journalists in the room. Just imagine you're in a physical room and you're having to give up your chair. So we need to prioritize the journalists because the situation on the ground is devastating. It's terrible and it's cruel, and we need to share our reactions and our reflections and our stories with the media, because right now that is the one important way for us to get information out from South Africa about the impact of the executive orders and the chaos that has been created by the Trump administration. So we really do appreciate your cooperation in this respect. We've got
Fatima,
5.
a couple of people I think have made room for about 23 more media people. And now we're at capacity again. That's what's happening.
Apologies to the media and everyone else. We did not think we'd have more than 100 people joining this press conference. We will make the recording available to anybody who can't join and to the media who can't join. So we do undertake to do that. I'm going to stop sharing the screen now. We would ask that unless you are a speaker for today or a co-host, to please switch your video off and to please mute. Because there's so many journalists for this press conference, we are going to obviously prioritize questions from journalists. You'll have to identify yourself, the name of your organization, but not in the chat. You will have to use the raise hand function. But we will first ask our speakers today to take us through some of the reflections and reactions from South Africa. Just to note, we're recording this, so that means that you all consent to your image, name, photos being used by any of the media that may be using this recording after this press conference. We will ask media that if you want one-on-one interviews or one-on-one comments or quotes, that you contact the media officer for this press conference, Angie Richardson. Joan is putting her details in the chat, and the interviews will be arranged accordingly. You will understand that people are dealing with a lot right now, especially communities, patients, communities, program implementers. And so we just need a system to coordinate the numerous amounts of media requests that are coming through. So we would appreciate it if you liaise with Angie Richardson on that. And we will share for all media. You can just ask Angie for the recording, and that will be shared with you after this. So without any further ado, on behalf of Change South Africa, welcome to this press conference. My name is Fatima Hassan. I'm just moderating the session for today, and my absolute pleasure in very trying times and very difficult times to hand over to Professor Linda-Gail Bekker from Desmond Tutu Foundation, who will be our first speaker for the press conference. Thank you.
Thanks, Fatima, and thanks to everyone for attending. It's my great honor and at the same time distress that we have to even have this conference. But I am going to try and set the scene a little bit and take us back somewhat historically so that we understand and set it up for Lynne and speakers after me to then drill down into the details of what we anticipate may be the aftermath of what has occurred. So just to be clear that despite the initial stop work orders that people received between the dates of the 24th and the 27th of January, there was then waivers issued by Senator Rubio in response to the fact that life-saving therapy and prevention of at least vertical transmission should continue. There was some instruction via the CDC-funded arm of PEPFAR to implementing partners to enable some of them to resume work. However, there has been a huge paucity of similar kinds of instructions via the USAID arm. Some people received some kind of instruction that suggested they might have to get budgets lined up, but very few people got a resume work kind of waiver on the USAID front. And the latest thing that has happened in the last 24 hours is that many of those USAID implementing partners, as well as non-PEPFAR R&D partners, have just received termination orders. So now requiring them to stop their agreements, to close out, and to really as if the whole story is now over. It's important for us to reflect about the President's Emergency PEPFAR Fund. So it was first instigated in 2003 in the response to the fact that people in the Global South were dying of AIDS, despite the fact that there was life-saving treatment to change that life course. So really taking HIV from being a terminal, reasonably rapidly resulting in death type disease to now becoming a chronic manageable condition with people living really into their aged ways, or as children into adulthood. At the same time, in 2003, we had very few prevention tools. So really, prevention was nowhere on the radar. It was all about the emergency of trying to save young lives and children's lives and prevent vertical transmission. Over the last 25 years of the PEPFAR program, many, many millions of lives have been saved and many infections averted. And through the evolution of the PEPFAR program, we have seen a transition. The transition has been towards countries assuming more responsibility for their responses, as the illustration here of South Africa, where we went from quite a dependence. You'll remember this was at the time of the AIDS denialism, quite a dependence on the PEPFAR program for our very antiretroviral provision, all the way through to now 80% of our response being funded through the national fiscus. The epidemic itself has evolved during this time. So importantly, we have got most of the 8 million odd people living in the country are now on treatment and accessing care. We do have the opportunity to provide primary prevention now. We do understand the natural history of this epidemic, and we know what needs to be done to bring the epidemic under control. In addition, we know that we can eliminate vertical transmission if we put all those resources to bear. However, we are not there. We are not at our 95 goal. We are still seeing far too many infections in this country. We contribute to a considerable number of new infections to the overall 1.3 million, and we continue to see vertical transmission to children. The PEPFAR response now, the 20% that has been much talked about in the last month or so, is critical for helping us bring that epidemic to its knees. And what do we need to do that? We need to bring our 95 goals into order, which means everybody we have not access for testing needs to be tested. If they test positive, they need to start antiretroviral therapy and become virally suppressed, if at all possible, if that is something we can get them to do. And those who are in areas where virus is being transmitted, that they should be able to access the prevention that works for them, including pre-exposure prophylaxis. Now, we do know also that our epidemic sits half of the new infections across this region occur in young women and girls, and the other half of all the new infections in the world occur in key populations. We have both of those kinds of epidemics in our country, and it's very important that we're accessing both women and the feminized epidemic, but also key populations who are what we call key populations because they're particularly vulnerable to HIV acquisition, but at the same time are incredibly underserved by our mainstream services in the HIV response. So this brings me to the point of what this 20% of funding has been. It has been about closing those specific gaps, about reaching the people who have not been reached because we haven't had our services where they needed to be, getting prevention to those people who may not be coming into public sector clinics because they are highly stigmatized or discriminated against, or in fact incriminated. And we have not been able to necessarily bring all the new tools and innovations to bear to the extent that we should have. And I know that Lynne will be expanding on some of the innovation that we have learned that we have not really brought to bear. And this is exactly what these dollars have been enabling us to do. We had a plan that in the next 5 years, the epidemic would be brought much more under control as a public health threat. And it could well be that by that point, donor aid would not be required in our program anymore because we would be ahead of the game. So what do we stand to lose? Well, many people have been trying to quantify what in fact may happen. And of course, sadly, unless we come in and fill those gaps, we will in the next weeks to months have a very good idea of exactly what the impact is. But some modeling studies are already coming through. One in particular that we published a week or two ago in the Annals of Medicine showed that if South Africa loses the PEPFAR funding over a 10-year horizon, whilst there may be some cost saving in the short term, in the longer term, we will lose money. And so that's the first point. We stand to lose all the investment over the last 25 years if we do not work hard to fill the gaps that this funding freeze is causing. Secondly, we will see lives lost. So in excess of 500,000 unnecessary deaths will occur because of the loss of the funding, and up to 500,000 new infections. So these are modeling studies. They are prone to various assumptions, but just to give the flavor that this is not going to be business as usual. We are going to see this epidemic walk back as a result of this. I do want to also say that PEPFAR has not only been the provision of aid to enable people, experts, community experts to be in the field, but it has also led to the generation of knowledge. So the first generation of knowledge is many of those individuals are collecting information, either in community-led monitoring systems or as data capturers, simply data capturers collecting information that enables us to hone the epidemic. The second important knowledge generation is none of these programs have run without asking, how can we do it better? What is a better way of solving this problem? How do you combine HIV and TB treatment in the modern era? That data is very important, and very important for us to acknowledge that that has been exported to the global community, and that will be lost. And then finally, not to forget that USAID has also been a very important partner for research and development, more upstream, if you like. So there were some very important programs that are stopped as of today, looking for an HIV vaccine that is relevant to Africa and the globe, looking for new prevention technologies that not only solve the HIV problem, but bring HIV and contraception, HIV and STI treatment together, along with many other very important programs that have been helping us catalyze and accelerate us being able to bring this epidemic to its knees and finally bring an end to it. And so I think as we take the toll on what this means, I think it is quite, it is not hyperbole to say that I predict a huge disaster, a walk back on the investment, unless other resources can be found and found urgently. And here I look to our own South African government urgently to say, how do we ensure that we fill the gaps so that lives are not lost, infections are not incurred because we have been caught sleeping at the wheel. I'll hand over now to Lynne Wilkinson.
Thank you, Linda. Lynn, before you commence, if I can just ask everybody on the call, we have journalists from lots of different publications who are in the waiting room trying to get in so that they can share our stories and testimonies and the impact. And as Linda-Gail has said, I predict a disaster, unquote. So it's really important for us to try and allow as many journalists as possible and the speakers, please, to enter the room. We do apologize. We didn't know that more than 100 people would join. If you are from an NGO or not a journalist, please, can we ask you to wait in the waiting room so that we can prioritize the speakers and the journalists so that we can get these stories and testimonies out. We really to appreciate it. Yes, there will be a recording. We'll be able to share the recording with all and sundry. But for now, because it's a press conference, we're really, really appealing to you to make way for journalists to be able to enter the room. So with that, I'm going to ask Lynn to take us through. Thank you.
Hi, everybody. I'm going to just carry on from where Linda-Gail left off. So as we've heard, the South African programs evolved and how the PEPFAR funding became focused on those hard to reach gaps, supporting children, pregnant women, men, people with advanced HIV disease, this is AIDS, key populations, community-based services, and what we call differentiated service delivery, which makes it easy for people to collect their treatments every 3 or 6 months outside of facilities. This wasn't duplication of government services. It was complementary, providing that final push to achieve those 95 targets and reduce our infections and our HIV and TB mortality. This is the entire HIV and TB program put at risk of unraveling across public sector facilities, communities, and key population services. My role is to explain a little bit of this impact so that I can provide some context. So in our public health facilities, we left with almost no data capturing. This means no monitoring and evaluation. This means we don't know who's come for treatment and who hasn't. And so we can't find the people who have missed their appointments and help them back. We've got very few counsellors left, which means no HIV testing, including for sick patients in hospitals. We have no treatment literacy and adherence support. We've got very little screening left for children in maternal and child health services. We have limited enrollment in differentiated service delivery models, which means we increase the burden on both clients and our remaining healthcare workers, increasing treatment interruptions and people disengaging from treatments. We have limited support for advanced HIV disease services. These are high-risk patients, including high-risk pregnant women, who are left without specialized care clinics. We risk a cessation of PrEP services. This is for adolescent girls, young women, and pregnant women who will lose their critical HIV prevention tools. We'll have limited TB screening and testing. These are TB cases going undiagnosed and fueling further transmission of TB and therefore mortality. In our communities, there won't be mobilization for HIV testing. So we won't test the people that are not accessing our facilities or their contacts, people who have already been diagnosed. There will be no recall or tracing of people who have missed ART appointments or received abnormal results. For instance, someone who gets a CRAG positive test is at risk of now not being treated for meningitis. We have our case management gone. Thousands of clients in adherence support models have lost their trained lay workers, including peer supporters who shared their lived experience. Our youth and family care clubs shut down. No postnatal clubs, youth adherence support, or male-friendly services. Limited TB contact tracing and preventative TB therapy scale-up, increasing the risk of TB disease progression in our vulnerable communities. For our key population services, this means our drop-in centres, our key population clinics, and our mobile outreach have shut down. No HIV testing, linkage, or treatment for people from key populations not accessing public sector facilities. No harm reduction services, needle and syringe programs, opiate agonist therapy for people who use drugs. Those have stopped. And then we mustn't forget the big role that USAID funding played in gender-based violence services. We already know of 87 facilities that were providing post-care violence care for 33,000 survivors last year, whose services will disappear. These are survivors of rape and intimate partner violence with no post-exposure prophylaxis to prevent HIV infection, no psychosocial report or legal assistance or medical care. We are really relying on the South African government to take the lead out of this crisis with a unified and coordinated response. Issuing the emergency circular was an important, necessary first step, and we commend the Director General of Health for this action. But our directive is only as strong as its execution. Beyond this, government must urgently develop a short and medium-term plan, including emergency funding allocations to sustain the service delivery, redeployment of trained healthcare workers and community staff to ensure the continuity of care, and a national coordination mechanism, an effective multi-stakeholder task team to ensure transparent decision-making, focused and clear timelines for action. We can't afford delays right now. We need clear prioritization so we can move forward. And civil society is here to join hands and work together with the government and the national department to keep our HIV program on track. Thanks. Over to our next speaker.
Thank you, Lynn. Again, sorry to be that person who has to keep on asking non-journalists, please leave the press conference so that we can make way for journalists who are in the waiting room, so that we can get the impact and the testimonies of what Linda-Gail and what Lynne has shared already, and what the next set of speakers will share with all of you. Remember that we still have a few more speakers. Next up will be Sibongile Tshabalala from TAC, will be followed, we hope, by Kholi, if she can get into the press conference as a speaker, from Sisonke, followed by Aurora from Aurora Kaleidoscope Movement, and then Yvette from APHA and Dr. Kate Rees from Anova Health Institute. So again, we're not taking questions as yet. We're asking people who are not journalists to please make way for journalists. Once all the speakers have completed their remarks, we will then be able to take questions from journalists. Thank you very much. Thibault?
Good afternoon, everyone. Thank you, Fatima, and everyone. As I'm introduced, my name is Sibongile Tshabalala. I'm the National Chairperson of Treatment Action Campaign. What I will share with you, it's mostly the work that we are doing as Treatment Action Campaign that is supported by PEPFAR through UNAIDS, and we are also affected by the freeze of funding. We are known as an advocacy group since our inception, and up to today we are still doing that and doing advocacy mostly based on the real data that we are collecting in facilities. So since in 2018, TAC has developed, working with PHIV sector, has developed the largest community-led monitoring system that is known by Rees. And we are systematically collecting data from over 450 clinics. And our dashboard is uploaded at the real time, and it's able to generate analysis for its own. And since 2018, we managed to survey more than 300,000 public healthcare users, and also more than 191 people living with HIV, and also more than 44,000 of key populations. So with these data that we are collecting, we always also generate community-owned solutions that are always give a feedback to facilities so that we can be able to manage and see the progress of what we are doing and how people living with HIV are receiving services. We managed to get more than 4,000 feedback meetings that were held in more than 53 community accountability meetings, where the Department of Health, PEPFAR, and other partners were part of that meetings, and those meetings yielded good results in terms of trying to fix the healthcare system and trying to fix the services of people living with HIV. So with all that is happening, we anticipate that more people will die, as Linda has explained earlier, to say we are anticipating deaths, we are anticipating more people being off treatment, and we know, all of us, that few days ago, I think 2 days ago, the Honorable Minister Aaron Motsoaledi has launched 1.1 million campaign. That campaign is meant to close the gap in terms of the people who are disengaging to care and people who are missing to care. So with all this is happening, then we are anticipating that the challenges of people disengaging to care will be more higher, because already we've learned through our data, through our community-led monitoring, that most of people are stopping taking their treatment, not because they want to do so, but because of the challenges that they are facing in our facilities. So with this 1.1 million campaign that has been launched, of which we are supporting it, but we are worried to say, if there is this 17% gap of funding, then how are we going to make sure that all people are serviced, especially key and vulnerable people populations? And we know for the fact, all of us as we are here, that young people are most infected with HIV, and over the years we've been fighting to say we need to reduce the numbers. Linda spoke at length about our goals, to say in the next 5 years we wanted to see no new infections in the country, and we wanted to give HIV another name, to say at least we managed to progress. But with all these funding freezes, it means we are going to go back. to where we were in the earlier days. So as an activist, as a person living openly with HIV, I just want to say here that I'm very hurt with what is happening, and it's very sad because it made me to ask questions to say, how am I going to survive? Will the public healthcare system be able to cater for us? Will be able to cover all the gaps that we are facing with all the challenges that the public healthcare system has at the current juncture? So that is one of the things that we are worried about. So one of the things that I want to close my speaking points with is to say it's time now. Government must act up and speed up the implementation plan to close the gap, because for us to continue to fight and ask for Trump Trump administration to reverse monies, we are not sure whether that is going to happen, because they've been ignoring court orders. But now it's a responsibility of our government to make sure that people of South Africa and surrounding countries are safe. So we need an action plan. We need to know what is happening. We need to know, because the circulars have been out there. How are they implemented? The 6 MMDs, is it implemented? In how many provinces? How is the progress report? Are people who are relocating from one province to another given treatment without demanding referral letters? Are people who are on CCMDT sites being able to be their rescripted automatically? How far are we with all that progress that we need to understand, so that we know when, as we were walking along with all the challenges that we have, we know how far are we. So we are not just waiting for our government to employ other agencies to administer or to investigate IPs. But what we need now, it's mostly what is important, an implementation plan. So we are calling for our government to step up and do something about what is happening. We can't afford to die. We can't afford to go back to those years where we are suffering with access to services, especially for people living with HIV, especially for key and vulnerable populations, especially for young people, and that we prevented as mothers not to be infected with HIV. Thank you, Fatima, for now. I think I'm getting emotional, so I need just to stop there for now. Thank you.
Thank you, Comrade Sibo, and it is a difficult time, so we totally understand and appreciate, and thank you for everything that you've shared with us today. Our next speaker is Kholi Buthelezi from Sisonke, and I think she just managed to join in, so welcome. So, Kholi, over to you.
Good afternoon to you all. Am I audible? Am I audible?
Yes, you are.
Can you hear me?
Yes, you are. You can proceed. Thank you.
Okay. Thank you so much, Fatima, and also for the extended invitation. Leadership Sibongile, I'm with you in this crisis. As I'm preparing myself about to speak, I also got too emotional. So in case you see some tears, you must understand that it is that a situation in the time, I think, of the tears, because I think we should also express ourselves emotionally to show how disappointed we are. So I would not ask people how they feel, because I know that the same feelings that you are feeling is the same feeling that I am feeling. I am so overwhelmed, I'm exhausted and frustrated by these orders that negatively impact in our lives. I'm Kholi Buthelezi. I think my name has been mentioned. I am the founding member of the National Sex Workers Movement in South Africa, the one and only that is calling for a decriminalization of adult sex work. And also I'm the director in my position. The blow and disorders, it has actually touched us and deeply concerning at the same time, because it feels like I've been having sleepless nights. I think I should be honest, because I'm also a key population member, thinking of my fellow, especially also within the Sisonke movement. We comprises of all key populations. So to us, this was very concerning, because we have transgender sex workers, we have female sex workers, we have male sex workers. You know, we are also parents, we are mothers. So this blow, it has actually reminded us of what my leadership, as Sibongile just said. You know, it reminds us of back then when HIV, there was no cure for that. So it's very concerning and alarming. And from this decision, it has impacted in our lives, health very negatively. This is very concerning and alarming in terms of HIV shutting down the entire malaria and the global viruses. It's very concerning. There's several key impacts that I know for a fact that with these stop orders, it has impacted negatively. The HIV prevention treatment, the access to healthy, stigma, you know that stigma is it is attached with the work we do. Stigma and discrimination, it also increases the vulnerability to violence. It has impacted community and organization. Employees of organizations in South Africa that really on PEPFAR USAID funding to run programs for the community, such as our peer education, outreach, and direct employees are left out. The halting of the funding, it does undermine the grassroots organization. Also, the work that we have done in progress to maintain the HIV in our countries. I feel like this stop order, it's actually taking us back. And in this situation, I think it's also important to highlight the fragile of the service provision when it is dependent on an externally funding, and also the importance of the sustainable locally driven solution to ensure that we continue support the marginalized communities. As we see, Sisonke, in the response of these challenges, the Sisonke National Movement and our allies are calling also government to increase funding from other sources, including the local and international government and also private donors. However, the gap that is left by the loss of PEPFAR USAID funding remains a serious challenge to healthy, safety, and the rights of sex workers in Africa particular. So it is very concerning to be in this kind of a situation where we feel that our hands are beyond controlling this situation. And also, it did not just only impact the sex workers because they are sex workers or key population, because they're key population. It has actually impacted our loved one, family members, you know, because sex workers are also parents. It is a nightmare that I cannot know how to explain it. And yeah, just to say, leadership, Sibongile, what you've just said, I feel it every day because I've been having a sleepless night these days lately because I'm also trying to think how best we can save our communities, because we know that some of the government health facilities are very discriminatory, and we're still working towards the sensitization of the government facilities such as SAPS, such as the social workers, you know, the healthy workers. We have not gone far, but we're halfway to make progress. And in this situation, I feel like that's a situation that has actually undermined all the progressive work we have done in South Africa in combating and fighting the HIV. It hasn't been an easy situation. We've been struggling because even the referrals, the service provision organization have reached out to us to say, can we then inform and alert our beneficiaries to come and collect the referral letter. We're having challenges as we speak of the communities, of our communities that are wanting to access the services, because the referral letter, it's what is needed. But I must say that some of the service provision have made an effort and communicate with some of the government departments, because they're not the same in districts, sub-districts, and in provinces. So we'll also be engaging in some meetings sometime next week with the some of the service provision that have reached out to the Department of Health to see possible ways of collaboration in making sure that sex workers are not left behind. And I think it's also important to acknowledge that there are some organizations that are trying and trying their level best to make sure that the sex work community is not left behind. But I must say that in this stop orders, there's nothing easy with the US stop order. And also to call the government, I think it is important to emphasize that part And for me, this stop order, it was actually a wake-up call, because as Sisonke, we're advocating for equal rights and equal access. So there's nothing specially that we need. But the challenge that we have is the stigma that it's a barrier within the government facilities, which is why there's existence of organizations. If our government was doing the right work, I don't think that would have much of the organizations, but organizations are doing the work that is supposed to be done by our government. And I think it's high time that our government also do open eyes and work with the constituency and also the key populations direct in making sure that what services that are needed to services that are needed to be implemented, because we are best and also the expert in this line of work. So we are availing ourselves to guide the government on what services are needed. You know, we need a holistic package, but we need to depend on our government. This thing of depending on the outside government of other countries, this is the results of that. So I think it's high time that our government do pull up socks and make services not friendly, because I don't like the friendly way people are doing their job, but they must render services. And just last point would be to say, in South Africa, if sex work was decriminalized, we wouldn't have all these challenges of depending on donors. But because of the stigma in the healthy facilities and the nature of work that we do, that makes our lives difficult. Thank you so much. I'll stop here.
Thank you, and I'm so sorry for having to cut you short. We could speak for hours, but we have a few more speakers to go, and the media also want to ask some questions. So we do appreciate it. Thank you very much. Our next speaker is going to be Aurora from Aurora Kaleidoscope Movement. Aurora, can you switch your video on and unmute, please?
Can you hear me?
Yes. Yes, you can go ahead.
Good afternoon. Kaleidoscope. What I basically want to unpack is how it affects clients, and to go on gender affirmation. As a client myself, at a clinic that provides gender affirming care, it's very nerve-wracking that our medication is now interrupted, and there's no immediate intervention has been put on the forefront for us. And as someone that have faced this before in 2021, and having to have that interruption of medication, one goes through detransitioning and psychological trauma. And from our side, we have been trying to reach out to government, and we see that there is not enough being done. There needs to be more done to ensure that gender affirming care is highlighted, and the access to gender affirming care, the need immediate intervention, and we need to be listened to. I, on my side, have been reaching out to the Women's Health Department to try and highlight that. But the response that I got is that once you go to a local clinic, what if we get denied medication? These clinics, I have sent out more in depth and trying to understand what is the actions of government in this instance regarding gender affirming care. And yes, thank you.
Thank you so much, Aurora. We were struggling to hear some of that, but just remember that if you are media and journalists and you'd like to request one-on-one interviews from any of the speakers here today or the organizations they represent, then Angie Richardson, our media officer, whose details are in the chat, can arrange that for you directly, unless you already have a bilateral relationship with any of the speakers. So we thank you again for your patience. There are still some people in the waiting room. Some of them are journalists, some of them are not. So we're just going to ask people to make space for journalists. And again, we will share the recording with everybody. We are getting some questions from media already. You can DM me or Joanne, just so that we can start a list. But our next speaker, our last two speakers, the next one will be Yvette Raphael, who is also an activist and also the executive director at APHA. Yvette, over to you, and that will be followed by Kate Rees from Anova. Yvette?
Fatima, my video is muted.
We can hear you. We're going to assist you with the video and you can commence.
All right. Good afternoon, everyone, and thank you for the invitation to be part of this press briefing. My name is Yvette Raphael, as already mentioned, and I am the Executive Director of APHA Advocates for the Prevention of HIV in Africa, also the Secretariat of the African Women's Community Prevention Accountability Board. We focus mainly on HIV prevention methods and research literacy. We do a lot of community engagement in all 9 provinces and in Africa. As I mentioned, some of our work is with the African Women's Accountability Board. We are deeply concerned about the decision to end US aid today. So we need to remember that the letters that came out said all contracts are ended. The Trump administration, according to our organization, has declared war on the right to health globally, not only in South Africa. We also need to reiterate that in South Africa, healthcare is a human right, and our government has an obligation to ensure that our human right, health right is reached. The South African government should take this as an opportunity to expedite universal health care and meet the obligations to our people. I want to mention that this is real life for many South Africans, more than 8 million people living with HIV. So we are not talking about just anybody. We're talking that this country has a high number of people living with HIV, and these are the people that I'm talking about. We also, what I hear, and many of the previous speakers have spoken, but we are not talking about the loss of income for these people living with HIV, for many in my community where I live and where I do my work. Most of the programs that we are talking about here are peer-led programs and are led by people with lived experience, as Kholi and Sibongile have mentioned, providing these community services for their people, by their people, who are often also breadwinners in their families. We are not talking enough about how they are losing their livelihoods today. Globally, women and girls carry the burden of new HIV infections. With HIV prevention programs halting immediately, we are headed for disaster. Many of these young people will not, of these women and young people will not be able to access the HIV prevention methods where they are used to, as many of their sites are closed today. With community engagement programs and advocacy programs halted, we as an organization only foresee disaster. And Sibongile spoke about the CLM program, which is actually on the dot reporting of some of the things that happen in our community. HIV prevention research happen in Africa, and we owe it to millions. Our governments owe it to millions of women. The US owe it to millions of women who make sure that they are part of this research. And we have to make sure that they access these medicines and the HIV prevention methods. The long-term effects of this is disastrous. If people are not accessing their treatment, we will see a rise in drug-resistant strains of HIV, and it will take us back to Mantu and Mbeki. With HIV research threatened, there will be no new development for new medication and discovery. And as LGB has mentioned, Linda-Gail has mentioned, disaster is looming. Our government not only needs to take and fill the gap, but they need to ensure that HIV research continue, because majority of people living in this country, people living with HIV are in this country, and we can no longer brag about being the biggest HIV treatment program in the world. it is a disaster. We do not want to see ourselves going back. And as my colleagues have mentioned, some of these things affect us personally. So we are not talking about people out there. We are talking about how this has real life impacts. If jobs are lost, people will not be able to afford their treatment, will not even be able to afford to go to the clinics, which are often far. And that is what these programs that were funded by PEPFAR USAID were doing. They were filling the gap. So we need to think clearly on how are we going to ensure that people living with HIV are not going to carry the further burden and die, as many of my speakers said, because of the lack of access to treatment as well as HIV prevention. The young people of this country deserve, and globally, as well as Africa, deserve a future that they don't have to worry about HIV. We were so close, and the Trump administration took us back. Thank you.
Thank you, Yvette. Our final speaker will be Dr. Kate Rees, who's a public health medicine specialist, but is also from the Anova Health Institute, which has been affected by the orders. And I think the common thread coming from all of our speakers and all of the messages today to the media in South Africa and elsewhere is that we're facing a situation of chaos, uncertainty, and disaster. And all of us are really looking forward to and eagerly awaiting the government's emergency plan, which, by the way, is under obligation to develop. So over to you, Kate. Thank you.
Thank you so much. Thank you for giving me this chance to speak. This is one of the worst days of my career, so it's really helpful to be able to be part of this platform. So I just wanted to go through a few things that we've discussed already. One being that because South Africa is not fully reliant on donor funding, partner support in the form of resources and skills, investment, has to some extent been embedded in primary healthcare services. And it's taken years, decades of investment to build up the systems that allow PEPFAR partners to fill the needed gaps in the HIV response. These are now being destroyed in 1 month. Plans were in place to shift the partner programs to become more and more sustainable for DOH to run and take ownership of over the next 5 years. And now, instead of a careful handover, we are being pushed off a cliff. So even though partners have focused on the gaps in the response, the impacts of this termination will be felt much more broadly. They'll be felt by everyone who uses or works in health services. Health is provided in a system, and this sudden removal of a substantial chunk of resources from a strained system will have knock-on effects. For example, waiting times will increase for everybody. That may not sound like such a big deal, but waiting times are already longer than most people can manage. People are out hustling for work, for income. They can't lose whole days waiting for medication. Our health services are already struggling under austerity measures. And with this, with increased waiting times, less accessibility to medication, more people are going to drop off chronic treatment, wait longer to seek help, and ultimately it'll end up costing our health services more when they're hospitalized, and it will lead to unnecessary deaths. As usual, the people most affected are the most vulnerable. So we've heard about some key populations already, but it's also people that cannot afford transport to the clinic every month, for example. Girls and young women who don't know what their prevention options are. Counselors who have dedicated their careers to helping people. Anyone who has worked in HIV knows how critical psychosocial support is. Counselors help clinic users to take in and understand their diagnoses, to access food support, to access grants. And these are some of the most affected services that we really need to see how Department of Health can step in and at least make a plan to stabilize these services. These are critical, and they will be one of the first to be forgotten and to be dropped. We've also heard how heavily data has been impacted. How could you imagine running a program of this size without quality, accessible data? It's impossible. And partners have been contributing hugely to data systems by providing data staff, including those overseeing quality, infrastructure, data systems, skills to build dashboards and help managers to use dashboards and to use data, and even purchasing diesel and inverters when load shedding hits. So it's really essential that we ensure that additional investments are made at primary care level and in these areas that are often forgotten, psychosocial support, data use, and so on. I've spent the last 9 years, and many of my colleagues have spent longer than that, working closely with the Department of Health at multiple levels to understand South Africa's HIV response and the gaps, to innovate and evaluate at primary care and community level to fill those gaps, to conduct small-scale, rapid research to improve the way health services are provided, and to find new ways to reach people that struggle with access. My plea is that the Department of Health engage and use partners and civil society immediately to maintain what we have built together before it is too late. Thank you.
Thank you so much, Kate. Once again, we just want to thank all our speakers and thank all of you for making time for this urgent press conference. We have a few questions in the chat that have come in from Reuters and Health Policy Watch. Just for journalists to also know that Mitchell Warren and others who have been part of some really important and pioneering legal cases in the US, where they've secured some court orders around reinstatement of projects and funding, but which cases are and orders are being defied by the Trump administration, is also on this call. So if you have questions, we can also deal with that. But we would like to focus on the impact on South Africa. So I'm going to ask Linda-Gail and Lynne, if you wouldn't mind dealing with the first question from Reuters, please, if you have that information. If you don't, we can always collate some of that information overnight and also send it to Peyton at Reuters. So if we could just ask all the speakers to also switch their videos on, that'd be great. Thank you. So let's deal with Reuters first and then Health Policy Watch second. So Linda and then Lynne.
So Lynne may have numbers. We can actually give the list of implementing partners in South Africa that have received termination notices. I think we pretty much have a good idea of exactly how many of those have received. And maybe, Lynne, we can get that and just put it in the chat. No, I don't think any of them got messages that their work could resume. I think that is on the CDC side. I'm not aware of anybody on the USAID side, but Kate could also maybe weigh in on that. No, so that you raise a very good point. I think it might be Nelly from Reuters. Is it a specific set of programs? So in other words, we know that there's an EDI concern that has come out of the current administration in the US. I initially thought this would target, programs that specifically are suited to what we call key populations, but in fact, this has been across the board, you've heard. This is children, this is orphans, vulnerable children, young women and girl programs. It is, generic and across the board. Lynne, I don't know if you want to, or Kate, or anyone.
Yeah, I think Kate's probably best placed, but I don't think we have numbers at the moment. We haven't heard of anybody not getting a termination. Perhaps we should say it like that. Every USAID partner, CBO, NGO that we work with has received one, and we don't know of anyone who's received a continuation. So perhaps that's where we are. We can't put numbers on it, but Kate can perhaps just talk about her organization's termination notice.
Yeah, I mean, I think there's I'm seeing a couple of questions and about the split in the CDC and the USAID splits, and it is really confusing, and I think it's intended to be confusing as well. But about half of the funding comes through USAID and about half through CDC. USAID has been dismantled first, and so our contracts have all been terminated. All the USAID partners were, well, many were asked to apply for a waiver and have done so, but none have received a waiver or gone back to work. Instead, all the contracts have been terminated. On the CDC side, things are looking different right now, but we don't know what the future holds. And, you know, there is a case for thinking that we can't say that those CDC funded programs are safe. So we shouldn't think that they've been spared. It may just be that it's taking longer to get to the CDC as opposed to USAID. Yeah, just to say, sorry, in my program, so we're just one partner of many big partners and many small partners who are equally important. But tomorrow, we are letting go more than 2,800 people. That's counselors, data capturers, healthcare workers, and these people are not going to find other jobs very easily. They're not ready and waiting for them.
Sorry, Fatima, I was just going to round this out to say that every single one of the R&D non-PEPFAR USAID funded programs have also received their termination. So 100% across the board.
Yeah. I mean, totally devastating and anger-inducing and heartbreaking, because we spent decades fighting for this and doing the research that all of you led and doing the community outreach work that the groups who have spoken here today have spoken about. So really a punch in the gut, and this is why we need government to step up urgently and to develop a proper plan with the right amount of funding. We're gonna try and answer some of the questions. Linda, there was a question for you and some clarity on the funding. Just to add from the moderator point, we do know that the minister said to Parliament that the 17% of PEPFAR funding, just PEPFAR, is worth about, if you do the figures and calculations, 7.5 billion rands. The postponement of the budget speech does not bode well for all of our work and for the missing money. And given the termination notices overnight for services for at-risk and key populations and general NTCT programs, HIV prevention, HIV treatment, TB prevention, screening, testing, I mean, it's systemic chaos. And unfortunately, I mean, we've been through this experience of anti-science and denialism. We've also been through the experience of fighting apartheid and dictatorships, and unfortunately, I think what we're seeing playing out in the US is really bordering on a dictatorship, which is gutting out and basically taking out all of our work that we've done all around the world in global health. So I don't know if Yvette, you want to answer any of the other questions about the impact on the ground, but there's specific questions directed to Linda-Gail on some clarity there. But I'm just going to hand over to the speakers to answer any of the questions that the journalists have posed. As well. A question from The Guardian as well, and Tamar Khan from the Business Day. So let's go Linda, and then Yvette, and then Sibo, who can speak to what's happening on the ground as well. And what are we saying to communities and people going forward now? How are they going to find information, and where are they going to get those services? I think it's another major question. Linda?
I'll pick up on the Guardian one quickly, just to say that the 17% that has been described for South Africa includes both USAID and PEPFAR. I'm sure in documentation we can find out exactly how that breaks apart, but I think Kate's right. It's the implementing partners about half-half. Some partners have more than one cooperative agreement, so that also needs to be taken into account. Suffice to say, it's vast and expansive. What I can tell you, sitting here in Nairobi, I'm ironically at an HIV and women workshop in Kenya. This is our region. So implementing partners that are funded by USAID throughout the region have received termination orders today.
Thanks, Linda. And there are two more questions for you about the UNAIDS report yesterday, the scale of other governments' funding, if you want to answer that, or you can pass on it as well. It's up to you. And then the other question was from Tamar about which research projects have been terminated as well through notices.
Yeah, I mean, you know, obviously we're same day we hear that UNAIDS is also losing its funding, which is, you know, again, just feels like the train crash is more and more incomprehensible. This does not bode well because clearly, you know, that UNAIDS leads the charge for us. And similarly, we heard a week ago, WHO similarly is losing their funding. It clearly makes us want to look to other potential funders around the world, whilst we clearly have to call on our governments to step up. But I think, you know, there's real concern about where Europe and other countries are themselves situated. We heard just yesterday that the UK is cutting their funding for aid. So, you know, I think it really is at a time when our governments are going to have to step up, and we see no way out of this other than you know, needing to see our own governments fill this gap. And here we're calling on the South African government yet again.
Thanks, Lynne. And research projects terminated. Do you want to take that now or later?
So the research projects, I didn't see the question. I can quickly describe what kinds of projects they are. There was one project called the Matrix Project, which is looking, as I sort of hinted, at new innovation for prevention, very short-acting methods of pre-exposure prophylaxis that can be combined with contraception. We know that this is, you know, a good way forward. Clinical trials were actually in the field and were stopped at the end of January, and they will not be resumed now. There were some prevention programs through the Mosaic program, actually giving out long-acting injectable cabotegravir. This is what Yvette was alluding to. This was provision of long-acting prevention for women and other populations in PEPFAR programs. Those were stopped, have been terminated. Those individuals have suddenly found themselves without the injectable pre-exposure prophylaxis that they had signed up for. We were looking for a relevant and affordable, effective HIV vaccine in 8 countries in Africa, really moving the science forward. We had 3 clinical trials lined up. All of those have stopped with the immunogen sitting in the fridge and not being able to utilize them. There are other important advocacy groups, APHA being one such that is a sub-recipient of CASPA and AVAC that runs advocacy for research and teaches communities what it means to participate in this research, but also be part of the broader HIV response. So important information generation and dissemination on the continent. All of this has been stopped as of yesterday.
Sure. Thank you, Linda. Totally, again, devastating. Let's take a few reflections from Yvette and Sibo from TAC who are on the ground. If you can answer some of the questions from Business Day, NPR, and some that I've included in the chat now. Thanks. And I think the question about the South African government saying, and the president saying earlier that it's a negligible investment, it's not a big deal, that we buy all of our own ARVs and everybody can be subsumed and integrated into the public health system. If you could just react to that statement and those kind of sentiments, please, would appreciate it. Thank you.
Thank you so much. Oh, thank you.
Yvette will go first. Sibo can wait.
Yeah. Thank you so much, Fatima, for those questions. And it's important for us to also remember that the government would say it's not a big deal, because on a daily basis on the ground, we are the ones who are experiencing the gaps that have been closed. And you can also see that this sentiment is all over social media, and it's misinformation, and people are starting to talk as if we can do without this very easily. So there's a big gap. He says 70%, 17%, which translates in billions, 7 billion rand that we don't have, that we do not know where it's going or where it's going to come from. But I want to pick up on something that Linda-Gail was talking about, the issue around the clinical trials being stopped. We must understand that those are very unethical actions to stop research in the middle when participants are receiving drug. It is important for us also to urge our ethical bodies in our countries to start talking about what this means. It is not the research sites problems. However, we need to make sure that the Trump administration understands that each and every country have their legal laws, and that those contracts that were terminated haphazardly has to follow the country's laws, including the labor laws of countries. And we are not at the apprentice where we just can say, you are fired. This is a real country. We are not playing. People are going to get sick. People are going to start having all of these side effects because of what is happening. We need to really urge our ethical bodies to stand up across Africa where this is happening, and even globally. We are going to face again vaccine hesitancy, treatment hesitancy. We are going to see a lot of people not believing in treatment, not believing in HIV prevention. And that is how we come a long way. As an organization, we did the groundwork. People, women, young people, understand these new HIV prevention methods, what they do to their bodies, and how they help them. We have seen young people go up to clinics to go and pick up their medication without anybody bothering them. We've seen young people going up and taking Cabernet. For it to be stopped so happy, just like that is a problem for us. And we need to also ask our government, can they not take this up and sue the US administration for this? It is not okay.
Thanks, Yvette. And just to add to what Yvette is saying, the US Congress approved the funds, and that is what has been stopped. So we do believe that it's an illegal grab. It's an illegal halt of services and programs. It's not following due process. And it's bordering on a dictatorship, because when you ignore due process and rule of law, and you ignore court orders, we know this, we've experienced this in South Africa, then that suggests to us that the US is becoming a dysfunctional democracy. It's not a democracy anymore, and the impact is huge, not just for people in the US. Key populations are also affected, services are also affected, LGBTI groups, sex workers, trans people, migrants, people living with HIV and other chronic illnesses are also affected by these orders. Women, pregnant women, people who want termination are also affected by this in the US. So it's something that is extending beyond, just the domestic impact in the US, but it's having global impact and effect. That said, we have a constitution in South Africa. We are a constitutional democracy. There is case law and precedent. We've all been part of that. We've worked on it. We've set up those laws and those precedents to ensure that everyone in South Africa gets the best possible healthcare for life-saving interventions. And to be honest, if it means we have to go to court again in the next 60 or 90 days, we will, because somebody has to bear the costs and somebody has to mitigate the costs of what is currently happening, and it can't just be the private sector. So over to you, Sibyl.
Thank you again, Fatima, and thank you, Yvette, for coming first. It's so sad hearing that our government saying 17%, it's not that much. But if you can look at the impact of that, not that much, it's huge. And it's so sad that it's coming from the same government that is unable to initiate all 8.1 million on treatment. If it was that easy, we're supposed to be all of us on treatment. So for government, it's easy to say that is not much, but for us on the ground, it's too much, because we know how much this 17% is doing for us. We know the work of the organization, NGOs that is doing on the ground. And that also answers the question from Spotlight to say, what do we say? We cannot say the government should absorb employees of implementing partners because we know they can't do it alone. And there's a lot of bureaucracy within the government that might take forever to absorb these. They are unable to hire doctors as we speak. As we speak, we are losing people on treatment because the public healthcare system cannot cater fully for us. And we were losing people while we have this 7 billion that was assisting us. But I don't want to say we failed because we have tried to work so much with our efforts, with our energy, going from corner to corner on the ground, educating communities, begging people to go to facilities, fighting for people to access a medication. As we are speaking now, there are people out there. There is a woman in Limpopo who cannot access her medication because she doesn't have a referral letter. We have to come in. If we don't have a single identifier system in South Africa, we cannot say 17% is not much. And who says that? A person who doesn't even use the public healthcare system. So we cannot continue to allow the very same government that doesn't trust its own healthcare system to tell us that 17% is not much. 17% means 15,000 jobs for people. 17% means so many lives for key populations that are unable to access our public healthcare services. Our Richitsa report showed it very well that most of key and vulnerable populations are stigmatized in facilities. They are unable to go into public facilities and get proper healthcare services without being stigmatized and discriminated. If they are saying it's not that much, we need a healthcare system that is working for every South African. Over the years, we've been suffering and crying to say our healthcare system is broken. And today, we are losing 17%, 7 billion, and someone comes and say that is not much. If it's not much, come up with a plan. Close the gap. We want to see everyone on treatment, not the 1.1 that we were talking about a few days ago. We need everyone to be on treatment so that we can fill the gaps, so that we can we will not have more infections, so that we can reach our goals as soon as possible. So I cannot listen to somebody who will come and tell me that 17% is not much, while they can't even employ doctors who graduated in South Africa, while doctors are leaving South Africa because there are no jobs in South Africa. If 17% is not that much, all doctors, all nurses, all healthcare professionals, posts should be filled. We cannot afford to continue to have austerity measures while 17% is not much. So they need to fill the gap. They know where the money is. They need to fill the gap. Then that means us as activists, we need to go on the street. We need to occupy that parliament and say, give us the services that we are supposed to get, because 17% is not much. Thank you very much.
Thank you, Sibo, for that passionate appeal. And I think it's a signal of where South African civil society is going, and that's legal action, mobilization on the streets, and if necessary, civil disobedience, also directed at the US government and US corporations. Just to put in context some of what Sibo was sharing with you, the circular which Lynne and I think Kate had talked about earlier in the remarks, which was issued by the Department of Health, a single circular in the last 30 days to deal with this crisis. And people are asking what's going to happen, what happens to services. The information that we have is that the circular provision have not been fully implemented. There are still legal steps that have to be given effect to, so that patients can actually access ARVs in a more seamless manner, and at least for a 6-month period. The second is that civil society groups, and Joanne has shared that letter, who have a track record of ensuring that the right to healthcare services is protected in South Africa, including litigating for ARVs, wrote to government on the 5th of February, including the presidency, including the health ministry and DIRCO. And we've been met with absolute silence. And we've said that you have a constitutional obligation to develop an urgent and a reasonable plan with appropriate funding sources to fill this important gap that Sibo is talking about. We've written again and we've said we expect a response by tomorrow, which is the 28th of February. We would ask journalists, because we are getting no responses from our government unless we go to court. The last few years have shown that our government only responds when we go to court. I don't see it playing out differently with the government of national unity. Absolute silence. We would ask journalists and we would appeal to you to ask government, where is the updated circular? Why is the circular drafted and issued if it can't be implemented? Where is the resources and funding to give effect to the circular? What is going to be the provision on an emergency basis in the budget that's due to be tabled in the next 2 weeks, the one that was postponed, to deal not just with the 7.5 billion, but all the other US funding that we also received through bilateral support, especially for the continuation of clinical trials. What is its emergency plan? And can it share, because none of us have seen it, the terms of reference with Deloitte and Touche, which it has commissioned to conduct over the next 30 days an assessment on the impact on the ground. Not sure why Deloitte was chosen. Open Secrets has written report about its role, particularly in state capture in South Africa, but that's for another day and another discussion. But we need to know about the circular and the updating of it and the resources and the funding. We need to know about the new budget. We need to know about the urgent plan that government is apparently developing, but behind closed doors, and none of us are included in that. We need to know what measures it's going to take, and we need to know the terms of reference of this Deloitte impact assessment review, or whatever they're calling it. Now, that was reported by IOL. We're not sure, it hasn't been reported by anybody else, but if that is the case, then all of us are really eager to know what the terms of reference of that are, because that would mean another 30 days. And this is what we said to government on the 5th of February, don't wait for the 90 days to expire, particularly for key populations who are at risk. You can see the ideological sort of sentiment seeping through all executive order after executive order. You need to start preparing now. And so that is why we wrote to government and asked for the sense of urgency. We do have about 12 minutes left, and we're very fortunate to have Mitchell Warren, whose organization AVAC has been actually urgently approaching the US courts for various types of relief to be able to benefit countries outside of the US as well. So not just on the domestic funding, but on foreign assistance as well. So I don't know, Mitch, if you want to just, for 1 or 2 minutes, just give people a sense of what's happening in the US and in your courts around trying to hold the Trump administration to account.
Great. So sorry, Fatima, can you hear me?
Yes. Yes.
So sorry about that. Getting off mute. Thank you so much. I want to thank you and all of the comrades who've spoken. Some of you know I spent my early part of my career in the 90s in South Africa. Everything I know about advocacy and activism is what I learned from all of you. And I'm trying to channel all of that 30 years later in the United States. And it is unrelenting. I never thought we'd be in a situation like this. We knew things were going to be different under the second term of this new president, but I don't think any of us recognized the speed and scale and inequity and inhumanity with which would happen. AVAC is actually an organization that works closely with a number of partners you've heard from. The program that focuses on advocacy and HIV prevention that Linda-Gail mentioned, we work closely with Yvette and Linda-Gail and many others. That is just one small project amongst many others. And we used that and our role in that to be one of the plaintiff on one of the 2 cases now filed to call out the illegality of the freeze. Certainly, we know that the US government's in a very strong position with any cooperative agreement or grant or contract. They're allowed to cancel agreements or amend them. They're in a very strong position generally, but the blanket freeze is illegal. And we have been now in a federal court for several weeks, and that has been confirmed, at least so far. A temporary restraining order was provided 2 weeks ago by the court that said that things had to go back, the tap had to be put back on until this 90-day review actually took place in a comprehensive way. And the government has intentionally, and we now have evidence entered into the public record in the courts that show the intentionality at USAID and the State Department to dismantle everything. But the government has simply thrown up additional legal delays, as is their wont. Last night in the United States, they asked for an urgent appeal at the Supreme Court, the highest court in the United States. That was granted a brief stay, which means the government doesn't have to make its payments that the earlier court decision in the day said they did. But the court case is on a very fast track and is being reviewed. We expect a hearing next week in Washington. That judge will make a decision. We expect it will go to the US Supreme Court. This is not about PEPFAR. This is not about the HIV response. This is not about USAID. This is about the rule of law, that the United States Congress has the power of the purse. They decide what gets spent. The executive branch is there to execute. And that's the basis of this legal argument. All of that said, and we now know they've acted illegally and they've documented what they've done badly. But clearly, as you all have heard last night, they began to basically massacre every possible implementing agency to deliver on this work. So this court case, as important as it is not going to change that overnight. And that's why working in partnership with each other and with national governments is so essential, because clearly the United States is not a partner that is trustworthy as a government entity right now. And so we do need every other government to step up. So that's the quick response. And again, honestly, I think for me, one of the most tragic parts of this is if this were just about PEPFAR or just about global assistance, that would be outrageous enough. But the fact that it is insidious across the entire facet of the United States, it's an authoritarian coup in action, and you all know it. You read it. The journalists on the line have reported on that. So there are a number of issues that interplay. We're focused on getting funding restored, but of course, as you heard from Linda-Gail and others, USAID staff are not there and won't be there. So we've got to think about what an architecture of the future looks like. There are holes in the dam that each of us is trying to fill, and we all collectively have to go upstream and build an entirely new dam together, and not rely on any government alone, not on any donor. This is our need as communities and as organizations. So I hope that provides a bit of context. We believe we will win in the court. The challenge now is, can we win in the court of public opinion in the United States to recognize that global assistance is not about helping poor people somewhere else. It's about making the entire world. And I believe PEPFAR is the best example ever of making not only the United States, but the world safer, stronger, and more prosperous. And anyone who says it's not doesn't understand what 20 years of partnership has created. And that's not just a legal case, that's a much larger issue. So I hope that helps provide you context. And I want to thank all of you again in South Africa, because you are leading the way, as you always have in 30 plus years.
Thank you, Mitchell. I think really powerful statements, insidious, authoritarian coup, and I think that's the sentiment on the ground. So we have a few minutes left, and there's a few specific questions, Linda-Gail, for you. I don't know if you want to have a go at that. And then I'm not sure if any of the other speakers, if you could just indicate by a show of hand if you wanted to respond to something specifically. The 500,000 figure, Linda.
Yeah, I'll pick that up, Fatima. Thank you. And sorry, people, I would answer, but I, for some reason, am not able to give my answers. Otherwise, I'd be answering this for you in real time. But just to say thank you to Joan. She did put the actual publication. It is open source there for you to read. But in a word, we modeled a half the amount, so half of the quantity, the 6 billion that you've heard about, coming to South Africa, it's stopping, and what the impact would be over 10 years, and then 100% disappearing, and what that impact would be. And I think probably one of the big take homes is, just that it will almost immediately start to have an impact on deaths, but also new infections. And to the beautiful point that Sibo made, is this brings it home that it is not just 17%, but how much more then in countries where it is more than 17%, where they are dependent on PEPFAR. And so, you know, whilst this is very much about South Africa, we have to be aware that the whole region is in deep trouble at the moment. And this has, and I cannot underline more what Mitchell's saying, is that this lets the region that has borne the brunt of the HIV epidemic, it really, in a way, lets the tiger out of the cage again, if you want to see it from a purely global threat point of view.
Thank you, Linda. And just want to echo that one of the countries that's most affected by the PEPFAR cuts, who were reliant for about 70% of their health budget from PEPFAR, is a country called Malawi, so our neighbors, and the impact on Southern Africa is going to be massive. Not that we're underplaying the 17%, but there are other countries that were heavily dependent on PEPFAR for a lot more funding and support. I think Kate has probably going to have the final comment. Kate?
Good timing. Okay, thank you. I just wanted to say, firstly, thank you, Sibongile, for that validation. After being told how unimportant we are, it was really nice to hear. But I wanted to talk to the question about the contracts relating to prevention versus art. And so we've got, Lynne has answered nicely in the chat that both, so it's everything that has been cancelled, and that PrEP was more significantly supported by PEPFAR, meaning that the South African government has less ability to provide PrEP at this point. But a lot of the contracts are, a lot of the money, a lot of the big, the big contracts that were receiving were to help just ordinary people get art, just everyday people in the clinic get art, to help prevention of mother-to-child transmission, to help everybody. So there is this clearly this disgusting ideological issue with prevention, but that's not, some of the stuff has nothing to do with that, and it's still all been cancelled immediately. So it's not all, there's no really sense to it anyway, but just to be clear that it's not only things that can be seen as counter to this current administration, it's also things that are routine services for people living with HIV.
Thank you. So we could go on for hours because I think this was so important. I think as a group, we'll discuss whether we have capacity to hold another press conference so that we can share real-time information with you, because I think there was a lot of interest from media. Apologies to those who couldn't join in on time or couldn't join at all because of the capacity. We will share the recording. Again, if you want a copy of the recording, you're going to contact Angie. If you want a one-on-one interview or quotes from any of our speakers, you contact Angie, and we will try and assist you to the best extent possible. And then just with that, want to thank all of the speakers, Professor Linda-Gail, Dr. Lynne Wilkinson, Sibo, Kholi, Aurora, Yvette, and Dr. Kate Rees. We really appreciate your effort and your energy and all the hidden work and also all the visible work. I think not enough recognition and thanks has gone to the entire community and the entire ecosystem that has been holding up the HIV and TB prevention, screening, testing program in South Africa for the last few decades. And it's unfortunate that our government is downplaying the impact for geopolitical reasons. I would just like to add that our president has said we will not be bullied. We agree and we'll support him to the extent that we can, but he also has powers and he also has the constitution. And right now, tomorrow, he can take measures to ensure that the cost of ARVs are reduced, to ensure that lenacapavir is available to everyone, everywhere, at an affordable price. And he needs to use those domestic measures against the US government now, because all the threats that have been thrown at us for the last 20 years have materialized. Nothing more that the US government can do to us. it's time to actually invoke compulsory measures against US pharmaceutical companies. With that, I want to thank you all, and yeah, be safe.